So, so today we'll start atrial flutter, but before starting atrial flutter, we have to see some relevant anatomy of the right and the left atrium. So I'll first show you that anatomy. For example, if this is your right atrium and this is your right ventricle. So this is your right atrium and this is the right ventricle. So you are seeing from the front, right atrium and right ventricle. Now if I do a cut section of this right atrium and I open the right atrium like this, so what you will see? You will see like this. This part is the interatrial septum and behind that is the left atrium. So this is interatrial septum. Okay, this part is interatrial septum and in between we have fossa ovalis. Fossa ovalis, which is the remnant of the foramen ovale. Now, we have right ventricle here. This is the right ventricle. And between right atrium and right ventricle, we have tricuspid valve. This is tricuspid valve. And in right atrium, we have opening of inferior vena cava. So this is the inferior vena cava which is opening. This is inferior vena cava opening in right atrium. Also, there is an opening of coronary sinus here, from where all the deoxygenated blood from the heart, myocardium, endocardium is collected in this. It comes through in the right atrium through this coronary sinus, and this part is known as coronary os. Coronary os. And then there is a ridge here, and this ridge is known as Eustachian ridge. Eustachian ridge. So I'm again revising. This is the right atrium. In right atrium, we have this part that is foramen ovale, which fossa ovalis, which is the remnant of foramen ovale. This is interatrial septum. This is coronary os, which is the opening of coronary sinus, where all the deoxygenated blood from the heart gets into the right atrium. This part is the Eustachian ridge. This part is the tricuspid valve or the annulus of tricuspid annulus. This is the IVC. Now, if you know these things, then what I want to show you is that there is a very important. Now, this area, which I am drawing with this color, this area is known as CTI. What is the meaning of CTI? CTI. CTI means C is cavo tricuspid isthmus. This is known as cavo tricuspid isthmus, this part. So this part is cavo tricuspid isthmus. Why I am emphasizing on this point, you will, after some time, you will understand why I am emphasizing so much. So cavo tricuspid isthmus is a area in the right atrium anterior to which is tricuspid annulus or tricuspid valve, or you can say cavo tricuspid isthmus is present behind the behind the tricuspid valve, or we can say that cavo tricuspid annulus is anterior to the IVC opening or Eustachian ridge, or we can say that Eustachian ridge and IVC is present behind the cavo tricuspid isthmus. Now this was when you are seeing right atrium from the front. Now I am showing you another. Now if I say that this is the right atrium, if this is the right atrium and this is the cavo tricuspid isthmus, which I have just shown. So anterior to cavo-tricuspid isthmus, what was there? There was tricuspid annulus. What was posterior? Posterior was opening of IVC and eustachian valve. And in the interatrial septum, there was fossa ovalis and coronary sinus. Also, we know since this is right atrium, there at the top we have, on the right corner, we have SA node. Okay. And this is your left atrium. And from the SA node to the left atrium, there a bundle goes, which is a parallel bundle, which transmit the impulse from SA node to the left atrium. And this bundle is known as Bachmann bundle. Bachmann bundle, or in short, we write it as a BB bundle, Bachmann bundle. Now, so this is cavo-tricuspid isthmus, which is present posterior to the tricuspid, and this is tricuspid annulus, this is eustachian ridge, this is your coronary os, this is the fossa ovalis, and this is the IVC. Now, whenever the impulse are generated in the SA node of the right atrium, so from right atrium to the left atrium, the impulses goes through the first, this majority through the Bachmann bundle, that is the BP bundle. Second, some impulse also goes through this, that is fossa ovalis. And third, some depolarization waves also go through the coronary os. This is the concept that you have to understand. Okay, so majority from right atrium to the left ventricle goes through Bachmann bundle, which are the parallel bundles from the right atrium to the left atrium. Second goes to the fossa ovalis, and third goes to the coronary os. This is a very important. If you know this anatomy, now you can, this will help you in the understanding the treatment, as well as understanding the ECG finding, and also in the classification of the flutter. Now, so you have to remember this part, that is the CTI, that is cavo-tricuspid isthmus. Now, if you have understand this, now I will show you some important point. There are atrial flutters are basically two types. One of the atrial flutter is CTI dependent. That means the current of that atrial flutter will pass through this cavo-tricuspid isthmus. And there are second type of atrial flutter where the circuit or the depolarization of the atrial flutter will not pass through this cavo-tricuspid isthmus. So we have to understand. So there are CTI dependent atrial flutter, and second are CTI independent atrial flutter. Now, so first we will understand. So 95% of the atrial flutters are CTI dependent. That means the depolarization or the current or the microcurrent will pass through this CTI. So what will help? So if we are somehow able to diagnose that this is a CTI dependent atrial flutter, we can simply ablate this CTI. And if we ablate this CTI, if we destroy this CTI, then atrial flutter will automatically be treated. There will be no need of further pharmacological treatment. Therefore, it is very important to understand that what is a CTI dependent atrial flutter. Okay, so now we'll again come to this diagram, but before coming to this diagram, I will tell you that atrial flutter classification. Atrial flutter classification. So one is CTI dependent. Now CTI dependent atrial flutter can be of two types. See, one, it can, this is the lateral wall of the right atrium, this is the interatrial septum, this is the superior wall, this is the inferior wall. So one of the type of CTI dependent atrial flutter can be that the impulse or the micro circuit is traveling in this way. It is coming through the lateral wall of the right atrium, then it is coming in the coming it is coming to the lateral wall, then it passes to the CTI, then it passes to the coronary os, then it passes to the foramen fossa ovalis, then it passes to the Bachmann bundle, then it passes to the superior triangle, superior surface, and then it again come to the lateral wall. So you see this is a anti-clockwise. So CTI dependent atrial flutter, one of the subtype is that is anti-clockwise or counterclockwise. And please remember this is the most common. 90% of the atrial flutter are 95% of the atrial flutter are CTI dependent and 90% of the atrial flutter are counterclockwise. So in CTI, this is the most common type. That is, they will come from the lateral wall, then they will go to the CTI, then they will go to the coronary os, then they will go to the fossa ovalis, then they will go to the Bachmann bundle, and then they will go to the superior surface. Now, if you will see, in this case, in that is in counterclockwise or anti-clockwise type of CTI dependent atrial flutter, how is left atrium being depolarized? You see, the waves are coming from the lateral wall of the right atrium, then they are coming to the cavo-tricuspid isthmus, and then first they go to the coronary os, then they go to the foramen ovale. So first left atrium will be depolarized here, then left atrium will be depolarized from the fossa ovalis, so it will be depolarized in this direction. Then finally it will be depolarized in the from the Bachmann bundle like this. So the depolarization of left atrium will be from inferior to the superior surface. So what will happen if, keep remember this point, in counterclockwise or anti-clockwise type of CTI dependent atrial flutter, left atrium depolarization wave will be from down to the up. Okay, this is a very important part. Now coming to the clockwise, in clockwise what will happen, the depolarization, the circuit will move from the superior surface, then it will come to the Bachmann bundle, then it will come to the fossa ovalis, then it will come to the coronary os, then it will come to the CTI, then it will come to the lateral wall. Both of them are passing to the CTI, therefore we are saying that both are CTI dependent, but this clockwise is less common. And in this clockwise, the left atrium is first depolarized from the Bachmann, then it is depolarized from the fossa ovalis, then it is depolarized from the coronary os. So depolarization of left atrium in case of the clockwise CTI dependent atrial flutter will be from upward to downward. This you have to keep this. So simply remember, in counterclockwise or anti-clockwise CTI dependent atrial flutter, left atrium is depolarized from downwards to the upwards, and in case of clockwise, the left atrium is depolarized from superior to downwards. Okay. So if you understand this, now we will come to the CTI atrial flutter classification. One is CTI dependent, one type is anti-clockwise, or it is also called as a counterclockwise, and this is the most common type of atrial flutter. And second is clockwise. This is the second most common type. So also remember that CTI dependent will originate from where? They will originate from right atrium. Then, so what happened that CTI dependent, what you will treat? You will simply do ablation of CTI. So they will have a very good prognosis. They will have a good prognosis. Then comes the CTI independent. CTI independent can originate from the left atrium, can originate from the right atrium, and they are very difficult to diagnose on the ECG, and they have bad prognosis. They have bad prognosis. Okay, so this you should keep in mind. Now you should understand what are the ECG finding. ECG finding of ECG finding ECG finding of atrial flutter. What are the ECG finding of the atrial flutter? First of all, very important point, when you should think of atrial flutter, because see, if atrial flutter is very simple in ECG, you will be able to easily diagnose it. But if it is a complex or moderate to complex, then it becomes very difficult. So whatever I am telling you, just keep that in mind. You will 99% of the cases you will be able to diagnose the atrial flutter. First, atrial rate is generally 300. It can be anything from 200 to 400, but generally it is atrial flutter rate is 300. So whenever atrial rate is about 200, you should think of atrial flutter, first thing. Second, ventricle rate is generally 150. Okay, now keep generally, I'm saying generally ventricular rate will be 150. Now the most common type of atrial flutter is no doubt CTI dependent, and in CTI it is 2:1. That is, if there are two beats of the atria, one is passed. So what happened in 2:1 is the most common type. So when the atrial rate is 300, ventricular rate will be 150. Also, if there is 3:1, then the ventricular rate will be 100, because only one third will pass. If the AV block is 4:1 type, then ventricular rate will be 75. So generally atrial rate is 300, and conduction, AV conduction block is 2:1. So only one of the two atrial beat is passed. So ventricular rate is 150. That's why we see generally this combination. But we can also see ventricle rate of 100 if the block is 3:1. We can also see ventricle rate of 75 if the block is 4:1. So, but these kinds of block are generally seen if there is a structural heart disease or drug induced. So these 3:1 or 1:1. Now you can also say that there can be 1:1. That means where atrial rate can be equal to ventricular rate. That means atrial rate is generally 300. So ventricular rate can also be, yes. This is also seen. This is especially seen in cases of WPW syndrome, because there is an accessory pathway. So every atrial beat is transferred to the ventricle. Please remember, they have a very high chances of going into ventricular fibrillation. So they are very dangerous. Okay, so and atrial rate, whenever it is 300 or around 200 to 400, you should think of atrial flutter. Then ventricle rate, whenever it is 150, you should think of 2:1 block. And in most of the cases, you will see this. In 3:1 block, you can have a 100 ventricle rate of 100, and in 4:1, you can have a 75. Third thing is sawtooth pattern. Sawtooth pattern. Sawtooth pattern in either you see in the inferior leads 2-3 AVF, or you see in lead V1. If you see this, then you should also think of atrial flutter. What is sawtooth? Sawtooth is like this. That means there is a upstroke and there is a downstroke. Upstroke is more acute and downstroke is less acute, and they are not pointed. So this is the sawtooth pattern. And please remember sawtooth pattern, the second point, whenever you will between, if there is a QRS complex here, QRS complex here, so if you will see the if you take two QRS complex and sawtooth pattern between two QRS complex will be just replica of the sawtooth pattern of the between the other two QRS complex. So that means the pattern will be same. This is very important point. Pattern will be same. That means if you take two QRS complex which have same RR interval, so you will see that this pattern will be same, exactly it will be similar to each other. So this is the fourth point. Next point, if you see inverted P wave in inferior leads, that is 2, 3 AVF, and erect P waves in V1. So this is the clockwise, this is the counterclockwise atrial flutter, which is CTI dependent. I have told you that in cases of counterclockwise, left atrium will be depolarized from downward to upward. So in the inferior leads, the depolarization will be going away from the inferior leads. Therefore, in leads 2, 3 and AVF, you will see a inverted P wave and an erect P wave in V1. I will show you in the ECGs. And just opposite, in cases of clockwise atrial flutter, there will be just opposite. Just opposite means now you will see a P wave in inferior leads, P wave will be erect. So these, if you have to keep these things in mind. What are the things? Whenever you see atrial rate of 300, first thing, atrial rate of 300 or between 200 to 400, ventricle rate of 150, especially in 2:1, and in most of the ECG of atrial flutter you will see 150. Whenever you see ventricle rate of 150, you should think of atrial flutter. But if it is a 3:1 block, ventricle rate can be 100. If it is 4:1 block, ventricle rate can be 75. Third, sawtooth pattern. What is sawtooth pattern? I have shown you upstroke and downstroke. Upstroke will be more acute, downstroke will be less acute, and the pattern between two QRS interval will be same. Then these are the 2 points to differentiate counterclockwise from the clockwise. In counterclockwise, I have told you that left atrium will be depolarized from downwards to upwards. So the inferior leads will have a inverted P wave. So inferior leads will have an inverted P wave, and erect P wave will be seen in V1, and just opposite in clockwise. So these are the 5 points that you have to keep in mind to diagnose atrial flutter. So now we'll see some of the ECGs to diagnose it. Okay. Now if you see this ECG, so first of all we'll calculate the ventricular rate. Okay, first let's see we calculate the atrial rate. So these are two P waves. One, two, three, four, five. So there are 5 small boxes. So heart rate is equal to 1500 upon n, where n is equal to the number of small box, or we can write 300 by capital N, where n is equal to the number of large box. So we'll use this formula. So here heart rate will be 1500 upon n. N means number of small 5, that means 300. So first thing is that atrial rate is 300. So first point is now proved. So we should think of atrial flutter. Now we'll calculate the ventricular rate. 1500 upon n number of small box. So if we see this ventricular rate, if we want to calculate, so this uh, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So there are 10 small box. Okay. So ventricular rate will be 1500 by 10, that is 150. So now we have very high chances that it can be atrial flutter. And what kind of atrial flutter? Atrial rate is 300, ventricular rate is 150. So it can be 2:1 type of atrial flutter. Now third thing is we will look for the sawtooth pattern. Sawtooth pattern we will see in lead, inferior leads or V1 leads. In V1 lead we are not seeing sawtooth pattern. Now come to the inferior leads. Now if you see the inferior leads, so you can easily see this sawtooth pattern. See, here you see this sawtooth pattern, sawtooth pattern. Now, what now you should see that in V1 the P wave are erect. In V1 the P wave are erect, and in 2, 3 and AVF the P waves are inverted. So in inferior leads P wave are inverted, and in V1 P wave are erect. That means it is which kind of atrial flutter? It is, yes, it is anti-clockwise type of atrial flutter, CTI dependent anti-clockwise. So now we have diagnosed that it is an atrial flutter with an atrial rate of 300, ventricular rate of 150. So it is a 2:1 AV nodal block, AV nodal block, plus it is a CTI dependent atrial flutter, CTI dependent atrial flutter, and which kind? It is anti-clockwise type. So this is how you have to go following. Now if you follow each step, you will easily be able to diagnose it. Okay. Now coming to the next question. Again, we have this question. Now, if you see the rhythm pattern, you will see that the QRR interval is not same. So most of the people will say that it is atrial fibrillation. But I have told you that if you see an ECG and you see irregular QRS complex, never say it is atrial fibrillation just by looking at it. Because whenever you have an irregular heart rate, it can be three things. It can be multifocal atrial tachycardia, it can be atrial fibrillation, and it can be atrial flutter with variable AV block. Okay, so in multifocal atrial tachycardia, it is very easy because you will see three different kinds of P waves. Morphology of P waves will be 5, 7, 6, so it is very easy. Now, how to differentiate atrial flutter and fibrillation? We will take two QRS complex which have almost same RR interval because it is irregular. So exact RR interval, exact same RR interval will be not found, but we'll take that RR interval which have almost same duration, and we will see the pattern. If the pattern is same, then I have told you it will be atrial flutter with variable AV block, and if the pattern will be different, it will be the atrial fibrillation. Okay, now if we see the rhythm step of this, let's take two RR interval which have almost same uh, same depth duration. For example, this and see this, they have almost same duration. Now see the pattern, its pattern is like this and its pattern is like this. So they have exactly the same pattern. Now, so they have same pattern. So what will be? So we know that this is a atrial flutter. So, in spite of in a hurry to diagnose this condition and atrial fibrillation, it will be a great. So, always in cases of irregular heart rate, take those QRS complex which have almost same interval and see the pattern in between them. If the pattern is same, that is atrial flutter with variable AV block, and if the pattern is different, it is atrial fibrillation. So now we have understood that this is a case of, this is a atrial, this is atrial flutter. Okay. Now, if we see, now we'll look for the sawtooth pattern. Sawtooth pattern, if you see that this is the sawtooth pattern. In lead 2, we see the sawtooth pattern. And even in AVF, we are seeing sawtooth pattern. And in V1, the P waves are erect. So that means it is again counterclockwise CTI dependent, because V1 mein P wave is erect. So what we'll say that it is an atrial flutter with variable AV block, or which kind of है ये CTI dependent with, और CTI dependent में भी कौन सा है anti clockwise. So always go through that algorithm. Now next ECG. See this ECG. This is again, you are seeing that this is a sawtooth pattern. V1 is erect. So this is again same CTI dependent atrial flutter clockwise. Okay. Here if you are seeing the ventricular rate, it is 1500 by 5, 10, 15, 20. That means 75. So ventricular rate is 75. Atrial rate is 1500 by 5. That is 300. So this is actually 4:1 kind of block. So here the ventricular rate is 75. I have told you, and atrial rate is 300. Sawtooth pattern is present. So I have told you this is a 4:1 kind of atrial flutter which is seen because of the drugs or some structural heart disease. Okay. Now see this atrial flutter. Now here, if you see the ventricular rate is 1500 by n, that is 10 around 150. And if you see the atrial rate, this is one atrium, this another is inside this QRS, so it is 1500 by 5, it is 300. So this is 2:1 kind of atrial flutter. If you see the sawtooth pattern, now you are seeing sawtooth pattern in lead V1. So you are seeing, and in 2, 3 and AVF, you are seeing erect P wave. So that means now this is a clockwise type of CTI dependent atrial flutter. So this is a clockwise type of CTI dependent atrial flutter with 2:1 block. Atrial rate of 300 and ventricular rate of 150. So you have to see this thing, okay? So you have to remember this finding. You have to go through this. Now you should know the treatment. Once you have diagnosed atrial flutter, you should know the treatment of atrial flutter. So it's just like atrial fibrillation. If it is acute, that is within 48 hours. So first thing you have to see whether patient is in shock or not. If patient is in shock, then what you have to do? You have to do electrocardioversion by giving 100 joule of biphasic energy. 100 joule of biphasic energy. If by this atrial flutter doesn't convert to the sinus rhythm, the next energy you will give will be of 200 joule. Please remember, in case of atrial fibrillation, the initial energy was 200 joule biphasic. Okay. In cases of SVT, supraventricular tachycardia, energy is 100 joule biphasic. In case of VT, it is 200 joule. In case of VFib, it is 200 joule. But in case of VFib, if you are giving monophasic, then it is 360 joule. In monophasic, you have to give more energy. Okay, so you have to give electrocardioversion if the patient is in the shock. But if the patient is not in shock, so you have to take care of three things. First is you have to anticoagulate the patient. Anticoagulate the patient. Why? Because atrial flutter can lead to the formation of thrombus into the atrium, and that thrombus can go into the ventricle, or from ventricle it can go to the brain and can cause stroke. So anticoagulation is done to prevent to prevent stroke prophylaxis. Second, you have to decrease ventricular rate. So anticoagulant, second thing you have to decrease the ventricular rate, and third you have to do chemical cardioversion. I will teach you everything. So these are the three things. First you have to do anticoagulation to prevent a stroke. Second, you have to decrease ventricular rate. Third, you have to do chemical cardioversion. So first you will see about anticoagulation. So which patient you have to do anticoagulates? You have to there is a score that is called as CHADS, CHADS VAS scoring, where C is for CHF, you give 1.2, you give 2.2 A, and you give 2.2 the S. Rest everything you give 1 point. So CHF you give 1 point, hypertension you give 1 point, age more than 75 year you give 2 point, D is for diabetes mellitus, you give 1 point, stroke history you give 2 point, vasculitis you give 1 point, age more than 65 you give 1 point, and female you give 1 point. So anybody who has the score of more than or equal to 1 will be given an anticoagulant. Okay, but please remember that score 1 should not come just from being female. For example, there is a female who doesn't have anything, and the 1 point is coming just because of the fact that she is a female, then that will be not considered. Okay, so point should be more than or equal to the 1, but this 1 should not come from the fact of that lady being just female. Okay, now So now you understand to whom you have to give anticoagulant. Which anticoagulant you can give? So you can use, we can give warfarin, you can give dabigatran, then you can give oral 10A inhibitors. Oral 10A inhibitors like rivaroxaban, edoxaban, and epioxaban. Okay, so we will start from dabigatran. So see, dabigatran. What is the dose of dabigatran? Please remember, if the creatinine clearance is more than 30, the dose of dabigatran is 150 mg BD. If creatine clearance is between 15 to 30, the dose is 75 mg BD, just half. And if creatinine clearance is less than 15, dabigatran should not be given. So dabigatran is not given in end-stage renal disease, or if the that is means grade 5 of chronic renal failure. So what are the uses of dabigatran? Now dabigatran is given, what we are reading, in the stroke prophylaxis of atrial fibrillation as well as atrial flutter. And dose I have already told you, this is the dose. It is also used in the treatment of, this is extra point I am telling you, treatment of DVT or pulmonary embolism. But please remember, here you have to give the bridging therapy. I take a separate lecture to tell you what is bridging therapy, because otherwise this lecture will be very long. Just understand that in bridging therapy, in initial 5 days, you give low molecular weight heparin or unfractionated heparin or fundaparinox. And after 5 days, you stop heparin and continue this drug. So that is known as bridge therapy. So you have to give, because these drugs, bridge therapy is given in those drugs which takes time to act. Their effect doesn't come within 1 day or 2 days. So in those drugs, we start low molecular weight heparin or unfractionated heparin or fundaparinox, and after 5 days, in the 5 days when the effect of those drugs comes, we stop the heparin. So that is known as the bridge therapy. So bridge therapy is given in case of dabigatran, and bridge therapy is also given in case of the warfarin. But if you see these newer drugs, rivaroxaban and epioxaban, here you don't need to give the bridge therapy. You also need to give bridge therapy in cases of edoxaban. So in edoxaban and dabigatran, if they are used in the treatment of DVT and pulmonary embolism, first you have to give the bridge therapy. So leave it there. So dabigatran, and what is dabigatran? Dabigatran is an oral drug. It is an oral drug, and it is thrombin inhibitor. It is a thrombin inhibitor. So it inhibits the thrombin. So when it inhibits the thrombin, fibrinogen is not able to convert into fibrin, and then clotting does not take place. This is the dose according to the creatinine clearance. And for stroke prophylaxis, there is no need of bridging therapy. But in cases of treatment of DVT and pulmonary embolism, bridging therapy is required with the low molecular weight heparin or unfractionated heparin or fondaparinux. Okay. Now, dabigatran, we all know what will be the side effect. Side effect is bleeding. Side effect is bleeding. The side effect of dabigatran is bleeding. But please remember, if you compare it with the warfarin, if you compare it with the warfarin, the chances of CNS bleed due to dabigatran is 70% less when compared to the warfarin. Or you can say that chances of CNS bleed during warfarin therapy is 70 times more as compared to the dabigatran. And now just the opposite of it. The chances of GI bleed during dabigatran is more as compared to the warfarin. So simply CNS bleeding, the chance of CNS bleeding is more with warfarin, around 70 times more chances, and the chances of GI bleeding is more with dabigatran. Now dabigatran comes as a capsule. It comes as a capsule. So since it comes as a capsule, you cannot break it or you cannot crush it and give in a patient of ICU who is having a RICE tube. So this is one of the problem of the dabigatran, that you cannot use in ICU patient because it is a capsule and you have to swallow it as such. So it cannot be given through the RICE tube. So it cannot be crushed and given through the RICE tube. It cannot be given in the ICU patient. This is very important point. So this was about dabigatran. This is the one anticoagulant that you can use. Second are the oral 10A inhibitors like rivaroxaban, edoxaban and epioxaban. We can also use them. For example, if we talk of rivaroxaban, so it is an oral drug. It is a 10A inhibitor drug. What is the use? It is again used in the stroke prophylaxis of what? Atrial flutter and atrial fibrillation, just like dabigatran. It is also used in the when in anesthesia after knee transplantation, or hip transplantation. It is given to prevent DVT. After hip transplantation, it is given for 35 days, and after knee transplantation, it is given for 12 days. Also, stroke prophylaxis, it is also given as a treatment of pulmonary embolism or DVT. And here, please remember, unlike dabigatran, no bridging therapy is required. So, in stroke prophylaxis of atrial flutter and atrial fibrillation, what is the dose? If creatinine clearance is more than 50, the dose is 20 mg OD. If creatinine clearance is less than 50, dose is 15 mg OD. Okay. Now, in knee transplant or hip transplant, both the dose is 10 mg OD. Okay, but in hip transplant, it is given for 35 days, and in knee transplant, it is given for 12 days. Now, in cases of treatment of pulmonary embolism and DVT, unlike dabigatran, there is no need of bridge therapy, and the dose is 15 mg BD for 21 days, and then 20 mg OD. Creatinine clearance should be more than 15. Okay, in ESRD it is not used. So rivaroxaban. Now, one of the important, rivaroxaban comes as a tablet form. So it can be chewed, it can be swallowed, it can be crushed, and it can be given through the RICE tube. So it can be very well used in the ICU. This is a very important point regarding the rivaroxaban. And the third drug was warfarin. We all know that warfarin is vitamin K antagonist. It blocks 2, 7, 9, 10, protein C and protein S, and the dose is 2 to 10 mg in order to maintain an INR of 2 to 10. Please remember, if you are giving stroke prophylaxis in cases of atrial flutter or atrial fibrillation, and the cause of atrial flutter or atrial fibrillation, and there is a mechanical wall or there is a valvular lesion, then the only drug which is approved is warfarin. For example, if you want to give a anticoagulant therapy for stroke prophylaxis in case of atrial flutter in a patient with mechanical wall, so you cannot give dabigatran, you cannot give rivaroxaban, epioxaban or edoxaban. You have to give warfarin. So in cases of the stroke prophylaxis, in atrial flutter or an atrial fibrillation, if the patient has mechanical valve or valvular lesion, for example, patient has atrial fibrillation out of because of if uh, uh, if it because of mitral stenosis, then you have to give warfarin. Okay. In mechanical valve, all those drugs, dabigatran, Rivotril, all are contraindicated. Please remember. So this was regarding the. So what we have seen, that if a patient is not in the shock, first thing is that we have to anticoagulate. Second is we have to decrease the ventricular rate. And third is we have to do chemical cardioversion. Now ventricular rate, because if the ventricular rate will be very high, diastolic time will be low and ventricular filling will be low, ejection fraction will be low, and symptom will be, the patient will have a lot of symptoms. Therefore, when we'll decrease the ventricular rate, diastolic time will increase, ventricular filling will increase, ejection fraction will increase, and symptoms will decrease. So ventricular rate, we can use beta blocker, we can use calcium channel blocker, and we can use digoxin. Okay. Beta blocker, we use metoprolol, and the dose is 2.5 to 5 mg IV, or then you can take it on oral dose. Oral dose is 50 to 100 mg in two divided dose. Okay, in calcium channel blocker, we generally take diltiazem, and the dose of diltiazem IV is, in adult generally we give 12.5 mg, but weight wise dosing is 0.25 mg per kg. Then oral dosing, it is 120 mg OD or 90 mg BD. Please remember earlier in atrial flutter and atrial fibrillation, it was thought that if atrial flutter or fibrillation is associated, we want to decrease the ventricular rate in atrial flutter or fibrillation, and it is associated with CHF. So people used to think that digoxin is the best drug, but now it has been seen that using of digoxin to decrease the ventricular rate in atrial flutter or fibrillation is associated with more mortality and morbidity. I am again repeating, use of digoxin to decrease the ventricular rate in atrial flutter or atrial fibrillation in patient of CHF is associated with more mortality and more morbidity. So this is one thing. Now, third is chemical cardioversion. That means you have to take a patient on either amiodarone or ibutilide. So what they do, that they can convert the normal sinus, they can convert the uh, non-sinus rhythm, non-sinus rhythm into the sinus rhythm. Okay. I have, in the previous lecture of atrial fibrillation, I have told their doses: amiodarone 150 mg loading dose followed by 60 mg per hour for 6 hours, and then 30 mg per hour for the 18 hours. And ibutilide dose is 0.01. If the patient is less than 60 kg, dose is 0.01 mg per kg given over 10 minutes, followed again after 10 minutes. And if the patient is more than 60 kg, you can directly give 1 mg dose. Okay. So I have told this in the cases of in the previous lecture. Now, so this was regarding the treatment. If the this was regarding the treatment, this was regarding the treatment. If the if the atrial flutter is acute. Now, if the atrial flutter is chronic, that means after 48 hours, what you will do? After 48 hours. So you have to see, do you have a TEE facility? That means echocardiographic, transesophageal echocardiography facilities available or not. If the it is not present. Why we see? Because we have to look for any, because after 48 hours there are chances that clot can be formed in atrium which can go to the ventricle and then it can go to the brain. So first we have to see, we cannot rely on the transthoracic echocardiography. So first, if we have a transesophageal echocardiography, if it is not present, we will give, you will follow 3C4 method. That means 3 week you will give anticoagulant. I have already told you what are the anticoagulants, what are the doses. Then you will do cardioversion, and then again 4 week you will do anticoagulant. Okay, so please remember why, because we don't have transesophageal echocardiography, so we'll give 3 week of anticoagulation. So that will remove any thrombus if present, and then we will do cardioversion. Now you can say that when you have given anticoagulant and then you have done the cardioversion, why you will give extra 4 week of anticoagulant? Because it has been seen that even after conversion to the sinus rhythm, in case of atrial flutter fibrillation, clot can be formed even after weeks. Therefore, an extra 4 week of anticoagulation should be done. I'm again repeating that in cases of atrial flutter fibrillation, even after conversion to the normal sinus rhythm, clot can be formed. So an additional of 4 week of anticoagulation is done. Now, if you have TEE facility available, what you will do? You will start anticoagulation. You will start anticoagulation. Then you will see through TE. If the clot is present, then you will follow again this rule that you will do anticoagulation for 3 weeks, then do the cardioversion, then you will anticoagulate. And if there will be no clot, that you will do cardioversion there and then you, what you will do? Then you will do 4 week anticoagulation. The reason being same, that even after the cardioversion, clot can be formed. So this was regarding atrial flutter, everything. Thank you.